So again, thank you so much for coming to the Infectious Disease Epidemiology Seminar Series brought to you by the Center for Communicable Disease Dynamics at the Harvard T.H. Chan School of Public Health. And I'm Kaya Joshi, and I'll be your moderator for this session. It's my great pleasure to welcome Dr. Carlos Grijalva as our speaker today. Thank you again for coming all the way from Nashville. So Carlos is a professor in the Division of Pharmacoepidemiology, the Departments of Health Policy and Biomedical Informatics at Vanderbilt University Medical Center. His research interests include the safety of vaccine-preventable respiratory diseases, the evaluation of medication safety and effectiveness, and methodologies of comparative effectiveness research. He's experienced in a lot of things, including the conduct of observational studies of medications and vaccine effects, and his research is particularly focused on influenza, SARS-CoV-2, and pneumococcal infections, and the evaluation of the effectiveness of vaccination and other preventive programs. So without further ado, thank you again so much.
Right. Good afternoon, everyone, and thank you for the invitation. It's very glad to be here on a very warm day in Boston. I think it's a little warmer than back home. So again, my name is Carlos Grijalva, and I am going to use the next minutes to tell you a little bit about some transmission studies that we have been doing. These transmission studies have focused specifically on viral infections. On viral infections, and the setting of interest is going to be the household. Okay, we will fix the volume. I want to display my disclosures. And next, I'm going to show you the outline of what I'm going to be covering today. So I'm going to start with a background for these household studies. I'm going to walk you through a very general conceptual framework to try to set up the conversation and start identifying elements that have relevance of the transmission of these infections and of these events within households. Then I want to introduce a couple of approaches that have been used in the past, and I want to specifically focus the rest of the presentation on one of those approaches and use one ongoing study that we have active now in the United States as an example of that approach. Then at the end, I want to walk you very quickly through some initial and ongoing observations apart from those studies that are currently ongoing. And I want to close by highlighting some of the challenges and limitations of these studies, and we'll present some conclusions at the end. So this is the first background information that I wanted to discuss with you, and that is just to try to think about what are the usual sources of information for infectious events. And those sources of information are usually represented from clinical encounters or surveillance systems that operate in a specific healthcare settings, to be outpatient clinics, emergency departments, hospitals. And we have access to that information, and that is incredibly helpful to identify and characterize the burden of disease. Those details and those data can also be used to conduct vaccine effectiveness evaluations and evaluate the effectiveness of not only vaccination, but maybe other interventions that can be used to assess their impact on the occurrence of disease. But those traditional surveillance systems usually do not allow us to study more closely how infections actually transmit, how infections transmit in the community, or how infections transmit in more concentrated environment in the households. And the households are of particular interest because this is our safe place. This is the area or environment where we usually are in very close contact with other household members. Those are our relatives, people that we care about. We're not very worried about being in contact with other household members for the most part. And This idea of using the households as a unit of observation where we can identify the occurrence of transmission events is not new. As you all know, there has been a number of studies conducted to characterize the transmission of infections, viral infections for the matter, for a long time. There have been several seminal studies that were conducted decades ago. They have provided a lot of the insight that we even carry today. A lot of information about the transmission of these infections in households come from those historical fascinating cohort studies, for example. Those studies were conducted in Michigan, in Washington State, etc. You know all the history of those studies. But separate from those operations that just focus on those specific locations and settings and sequence of seasons, there is a renewed interest in reviewing again or try to understand how these household settings facilitate or permit the observation of these transmission events, especially when we have experienced pandemics. So this happened in 2009 with the influenza pandemic. This has happened again during the most recent ongoing pandemic. The next slide is just one slide that tries to summarize a lot of information that was compiled in a systematic review that was presented during the early phase of the pandemic. This is the COVID-19 pandemic, and this group compiled information from a number of household transmission studies that have started describing the occurrence of these secondary infections in the household. They observed that there were a number of studies that were based on contact tracing activity. It was just taking advantage of information that has been used for a different purpose. A number of those studies at the time have been conducted outside of the United States. And one thing that is very important to highlight in this initial systematic review, there has been two additional iterations of these reviews with updated information and more studies included in those, was that the methodology is varied quite substantially. Not only the methodology is varied quite substantially, but also the estimates of the secondary infections varied quite a bit. So in the meta-analysis of this initial systematic review, they estimated that the secondary infection rate was about 20%, but you can see the range of the estimates provided by the studies reviewed in that initial review, from almost 4% to almost 45%. So a very wide range. So there are a number of elements that play a role in this diverse set of estimates. And this is a slide that I like to use as a conceptual framework for the elements that are usually playing a role in the transmission of viral infections within households. So we have a little representation of a household, and then we have a representation of environmental elements that may play a role in the transmission of these infections. Temperature, ventilation, relative humidity, the number of household members, maybe the structure of the household or the building itself can be important to take into account. There are other elements that pertain more directly to the members or even the host or the individual who brings the infection into the household. Those relate to the demographic information, maybe comorbidities. Of special interest is the immunological status of the individual can be affected by vaccination, maybe prior infection, the way that these individuals interact with each other, and the contacts that they may have established with the individual who is bringing the infection to the house in the first place can be very important to characterize. In addition to all those elements, there may be other features of the specific pathogen. The virus of interest may have some specific intrinsic features that may facilitate the transmission among household members. So all of these is just to highlight that there are a multitude of elements that play a role in the transmission of these infections in households. And the challenge usually is to design a study that allows us to have a good characterization of these elements that we think are relevant for the transmission. So what can be learned from these household transmission studies? I'll try to make the case that there are a number of things that we can learn from these studies. So one is to understand this chain of transmission. What happens after one individual brings the infection for the first time into the household? What happened to the individuals that are exposed? We want to understand how fast these infections occur and what is the ultimate incidence or the risk of getting exposed if you live in a household where the virus was just introduced. we can learn about the pattern of transmission from person to person. That requires a more granular assessment to characterize the contact interactions or potential exposures that individuals have with other members in the households. We also need to understand that the households don't get blocked or closed after one infection or transmission starts occurring. There are other potential sources of infections that may be coming from outside the house, and it's important to characterize those to the extent that is possible, so that we can very clearly assess what is the intrinsic in-house risk. For that, we can assess contacts, we can identify the viruses that are identified in the individuals, do sequencing or maybe modeling to try to help us figure out what is the proper chain of infections and who passed infection to whom process in that assessment. We can also use these studies to evaluate and understand some of the transmission parameters that we sometimes use for modeling exercises. So household transmission studies can be helpful to estimate serial intervals, to characterize shedding patterns, to characterize the infectiousness of the individual. So not only based on molecular detections, but also whether it's possible to isolate viable viruses from specimens collected from the individuals. We can have a better understanding of how the contacts or the household members that live in the household that is exposed to a new virus can be susceptible to these new infections, or what are the factors that can modify that susceptibility. And at the same time, we can identify whether there are some factors that affect the ability of an infected individual to infect others in the household when we think of terms of infectivity. And we can use this information to have a better understanding about what is the role of a specific host characteristics, maybe understand better what is the impact of vaccination efforts. Vaccine effectiveness is something that comes to mind, but not only that, but also to understand what is the effectiveness of preventative measures, isolation, quarantine, or other measures that individuals may be adopting while they're in the household. And ultimately, this setting where we can identify chains of transmission within individual households, if we project that to a longer perspective, maybe the platform where interventions can be deployed and we can test formally in a more rigorous way whether some interventions may mitigate the risk of infection. So as I mentioned earlier, there are different flavors of these transmission studies, and these are household transmission studies. Again, this is a nice representation from the article that is referenced in the slide. The idea in this representation is that there is a time when there is circulation of the virus, and you have two options, or two are the options that we're going to talk about today. One is a cohort study where you enroll a defined population of households. Each household may be your unit of analysis. You enroll them over time. You enroll them at a certain time. You don't start the follow-up just yet. So you need to do a census, field census operation, identify the households. And at a certain time, you start the follow-up for them, ideally within a very close time window, so that the whole population of households goes through the respiratory season. You can establish effective ways to identify when these households get exposed to these events and characterize the occurrence of infections within households in that way. So you start with a population of households and you expect to observe some events when you follow this group of this population of households over time. That study in itself is very labor intensive. You can imagine that if the season happens to be a relatively mild season or the infections are not very common, the number of households that you need to have enrolled and maintained under observation is going to increase very rapidly. So that can be a very complicated process if the disease is not very common, and then you may need to have a large number of households and a larger effort to enroll more households and to maintain them under observation for a prolonged period of time so that you can accumulate enough observations. So that is in general the very basic representation of a cohort study for households. We're not going to get into the details of what happens after you get into you identify one household with infections. There is a lot of very close assessments that need to occur so that you can characterize who passed infection to whom, what is the information about what contacts were happening, how were individuals were experiencing symptoms, and so on and so forth. Okay, but that is the big picture for the household cohort of the study. I'm really going to focus on the other approach that is an alternative and is thought to be more effective. It's not the perfect design, as we're going to learn and review the challenges at the end. But the second flavor of these household transmission studies is the case ascertained household transmission study. It's listed here as a transmission study. The idea is in some ways similar. You identify households that are amenable to participate in the study. The households are actively enrolled or are actively followed once you know that there is an infection introduced into that environment. Once that information is in place, then there are a number of activities that the studies put in place to characterize all the sequence of events over time. Okay, since you start by enrolling households where you know that there is an infection coming in, that study is much more efficient, let's say, than cohort studies where you can follow really a large number of households and sometimes not have sufficient transmission events. So we're going to focus on that case ascertained study for the rest of this conversation. The study that I want to use as an example is an ongoing study that we are doing right now. It's called the Respiratory Virus Transmission Network, Sentinel. So there is another version of this study, but we're focusing on the Sentinel version for now. It's a case ascertained study, and the idea is to characterize the occurrence of these secondary infections in households with a special interest in trying to understand how vaccines can influence these risks of infections. We'll talk a little bit about the specific interest in trying to assess susceptibility or the effectiveness against susceptibility and against infectivity. But in general, this study is focused on two pathogens. So we're identifying and enrolling households who have a first introduction of an influenza infection or a COVID infection. And this is done at 7 sites within the country. So you can see the location of the site. So we have a nice geographical distribution of those network sites in the country. And Vanderbilt is serving as a lead and data coordinator center and central laboratory for this study. So as I said, this study is a case ascertained study, and I want to try to represent with an animation what we are doing for this study. So I told you that these studies identify first an eligible index case. And this is the first person that lives in a household where there are other individuals that could be infected. It's the first individual with a disease that has a confirmation of an infection. Okay, this person is represented in red there. And we know that this individual lives with other individuals that are potentially at risk. So at the time of the enrollment, we know that there is only one person that is infected, and that infection is confirmed. They all live in the same environment, and these individuals are rapidly identified and enrolled. Okay, they get approached, they're walked through the consent process, they're consented, and then their enrollment and follow-up starts. At that time, we plan to follow them on a daily basis for 10 days. And that is the acute follow-up phase of the study. The enrollment needs to occur very fast because we want to capture and get an opportunity to observe the transmission events. So the median time from clinical test to enrollment on our side is 1 day. So it needs to happen very quickly, right? Because we want to have an opportunity to observe those transmission events. So that when we start following these individuals on a daily basis, we can see the transition from someone that was not sick to become an infected. Could be symptomatic or asymptomatic. Okay, but that's in essence what we're trying to do with this case ascertained study. We have additional follow-up measurements, 35 days follow-ups, and then another one at 90 days. I'll describe those in more detail in a second. But every day we are collecting information about symptoms. So there is an effort to try to characterize in detail what is the experience of these individuals with the infection in the household. Characterize contact, characterize symptoms, what treatments they receive, not only for the infection, but also for symptoms, just so that we can characterize symptoms in an accurate way. We train participants so that they self-collect a nasal swab every day during 10 days, so that we can have a good ascertainment of infections. And this is done regardless of the presence of symptoms. So symptoms or no symptoms, we get a daily nasal swab from the participants. And in an attempt to characterize immunological status of these participants, we also collect the specimens, blood specimens at the beginning, and also on the 30 days after enrollment. So an acute and convalescent measurement. These specimens are collected again across the country from these 7 sites. And we have 2 pathways for collection of the specimens. One is based on a media that is stable at room temperature and preserve the genetic materials that we use to identify viruses for 7 days after inoculation. So we have some opportunity to manipulate these samples. The transport media inactivates the virus, and so it facilitates the logistics for transportation. And that is one flavor of the specimens that we collect. The other set is collected in VTM and viral transport media, and those are the ones that are collected, are more labor intensive because they need to be refrigerated within 72 hours of collection, but those are the ones that we use for culture, for viral cultures and isolations and determinations of infectivity. So 2 options that these sites are working on. This is information for data collection. I want to spend some time just walking you through the different data elements that are collected as part of this structure. So you recognize the initial D1 or the day of enrollment. That's the time when the information is collected. Individuals are enrolled. They provide some initial sociodemographic information. That's the time when they're consented, and they're consented remotely over the phone. So we collect basic enrollment information, and once they are consented, we ask them to complete a more detailed follow-up enrollment survey with complementary questions that they can complete during the next 3 days. So we try to keep the length of the conversation, phone conversation, short, because the consent form takes a lot of time, as you can imagine. We ask for contact information. I was telling you about the relevance of understanding who get in close contact with whom, and we do this assessment at different time points. So the first time that we look into is the time, this is a day prior to the day when the first household member experienced symptoms. So the day prior to the disease onset is the first day that we target to assess household contacts. Our plan is to use that information as a surrogate of what would be the regular contact patterns that those household members experienced when there was no one infected. Okay, so that is done, and then we do a similar assessment on the day prior to enrollment. That's the day when the infection is known to exist in the household. So that we call that the enrollment contact assessment. And that reflects usually some isolation measures that the households are implementing just because they just became aware that there was one person infected. And we do the same assessment at the end of the 10-day follow-up to complete the characterization of the contact pattern household. To complete the representation of the clinical course of the disease and the clinical management that these individuals may have received, we collect baseline data. So we retrospectively assess information starting on the day prior to the first symptoms experienced by the individuals or the first test positive that these individuals had. And so we complete information from those days, and we connect that sequence of baseline diaries with the daily diaries that are sent to them on a daily basis. So we can characterize when disease starts and what happened with the symptoms and the management that they receive over time. Then we have some follow-up measurements. We have 30 days assessments that are focused on, again, the convalescent blood specimen. And also we assess productivity losses at the time. So there is an interest in trying to understand how the acute infection impacted the productivity of the adults in this case, who were infected with COVID, influenza, or not infected with these infections. And then we have a more distal 90 or 120-day assessment, which focus mostly on the persistence of symptoms that originated with this acute infection. So that is more geared towards the persistent COVID symptoms, long COVID, past, et cetera. This is a representation of the structure of this network. I'm going to walk you through this very quickly. We have a data coordinator center in the steering committee that works closely with CDC that manages a central protocol that is applied to across the different sites. Everything is governed by a single IRB process. And this group designs a single REDCap structure that is disseminated across the site. So we all answer to the same questions, and we have a standardized process to collect specimens. And all of those specimens and data are again centralized in this REDCap process, including the indexing and shipping of the specimens to our lab. And after this specimen and this data come to our lab, the samples are tested at Vanderbilt first, and then disseminated to two additional channels. One to the University of Michigan for viral sequencing, and the other one is to Emory University for viral cultures. But all those results are ultimately centralized, and Vanderbilt again centralizes the data and puts together the databases in coordination with CDC and execute data analysis. So this is a large operation that have a multitude of objectives, and as you can imagine, we're trying to answer the questions that we can with this initiative. One of those is to estimate the attack rates of SARS-CoV-2 infections and influenza virus infections among household members. We try to understand what is the effectiveness of influenza vaccines as they apply to index cases, to try to understand how vaccination of these index cases influence the infectivity, their ability to pass infections to others in the household. We also try to understand what is the effectiveness of vaccines for the household context. So how these vaccinations modify their susceptibility to an infection that is brought into their environments. And we try to understand some other factors, could be individual level or household levels, that may impact the risk of transmission. Okay, so I want to accelerate a little. I know we're getting behind in time, but this is just a graphical representation of some of these elements that I was just mentioning. This is specifically related to vaccine effectiveness assessments. And if you think about this as a household with a representation of an index case in red and household context in blue, we can think about the effectiveness of the vaccines to modify the effectivity of the index case if we focus our attention on contrasting vaccination status just for the index cases. We could do an assessment of vaccine effectiveness assessments of the susceptibility. We focus on the household context, and we contrast vaccinated and unvaccinated household context, and we get the combination of a total vaccine effectiveness when everyone is vaccinated versus not everyone is, when no one is vaccinated in those households. So these or previous iterations of these case ascertainment studies have been used and are being used for some initial assessments of this process. Our larger network is close to end enrollment within the next, it's planned to, we're going to hit our target number probably in 1 or 2 weeks, but we're going to continue enrolling for 2 more months. But that should be completed soon. So this study, the study that I'm displaying here is an early study that was published in 2020. This was based on just 2 sites, in this case, Vanderbilt and the Marshfield Clinic in Wisconsin. And it was helpful to apply exactly the same methodology that I just explained to you. This time, the follow-up was 2 weeks. That was the beginning of the pandemic. And this study helped identify the very large number of infections that occurred in the household after this initial infections were identified. The proportion of individuals who were infected after the index case was identified was really high, close to 53%. When we remove members who had a first specimen positive and recalculated the proportion, it was 35%. So even with that very conservative estimate, at least 1 of 3 individuals exposed got infected. And I think we have seen a number of iterations of similar reports on that. These studies, because are longitudinal and provide daily characterization of detections and symptoms, also allowed us to look into what were the implications of changing duration of quarantine recommendations. So you remember, you may not remember, but that maybe a few years ago, there was this very rapid sequence of changes in recommendations. And part of this information was used to provide an estimate of what would happen if you release or remove the quarantine recommendations on day 7. And there was a small but observable risk of additional infections that may occur in the household at that particular point. This is a complicated figure. I'd like to draw your attention to the column in the middle. That's a series of estimates of secondary infection risk. This is just looking into household contacts. And this study was trying to provide some information about what was the role of children in facilitating the occurrence of these infections. The numbers are small. These studies are very labor intensive to conduct, but you can see that the secondary infection rates for most of the age groups, this is the first panel that I'm referring to, were relatively similar except for the adolescents, which had a much lower secondary infection risk according to these estimates. And if we think about that adolescents at the age of the primary case, then we see that is the lowest secondary infection risk. You see the panel in the middle, when you look at just the contacts, those are the age groups of the contacts, you see that the secondary infection risk is more or less the same. In this study, we're trying to do an initial assessment on whether contacts between individuals or among individuals may favor some infections. And this is a very crude way to try to get into these correspondence, because one of the main drivers of interactions within or among individuals is usually the age group. So you can see at the very end of this figure, the characterization of secondary infection risk when the age group of the index case and the household contacts were the same, and they tend to be a little bigger. So that again is a very crude characterization of that process. In the same report, this was examined in a little more detail. What you see in the first column is the age of the index cases, and what you see in the symbols is a representation again of the secondary infection risk. When the age of the primary or the index case corresponds with the age of the contact group, the risk of infections tend to be higher. Again, just trying to align with that hypothesis that there is a strong correspondence and quite higher intensity of contacts among individuals who share the same age. So again, this is an indirect characterization of that process. We're doing now a more detailed assessment, taking into account this individual contact information that I was telling you before. What we're observing is that there is a very rapid reduction in the density of interactions after the infections become known, which is naturally what we would be expecting. But we're working with a group in Belgium, in Hasselt University, to try to model what is the impact of this process. And there are two scenarios that we're trying to contrast. So one is the scenario that is observed, where individuals share regular patterns of interactions up to the point when the infection is known, and then they shrink their contacts, right? That's a natural process. And that is what is represented in this onset plus enrollment, that very first box plot. And the second part, the contrast, the second representation is just the same simulated epidemic based on the contact patterns, as if they knew from the very beginning, from the disease onset, that that person was infected, and they apply those contacts. So if you make the contrast between those two scenarios, and this is just a simulated spread of the epidemic within the households, then you get to see that difference final size. And so this is work in progress that is going to be released very soon. But that is one way for us to use the contact information that I was describing. Because we have this daily characterization of symptoms and also specimens. This is an early representation of an indirect measurement of viral loads. So this is focused on CT values, and the y-axis is reversed. So higher values represent, as you know, less viral loads. We can see that the viral loads for children tend to be lower than the viral loads detected in adults. And this is the reverse is seen in older adults. This was done first using CT values. There are different platforms there. As you know, the CT values are just surrogates for the viral loads. So in the current study, we are doing WHO standardized characterizations of all the viral loads that we have. So we have a more complete and comprehensive assessment. I'm going to finish very quickly. This is just to show you that these studies are also looking into secondary infections of influenza, a number of reports in the past. We had the opportunity to do an early assessment for what happened in the 2021-2022 season. You may remember there was a circulation of an influenza subclade that was not covered by the vaccine. And there were some concerns about that event. And we recently released this report that is just looking at the secondary infection rates of influenza during the 2021-2022 influenza season. And the secondary infection rates in households looks quite much higher than what had been observed during the previous seasons prior to the beginning of the pandemic. We don't know exactly what is driving that change. We're keeping a close eye on what is happening during the current season. But this was just very specific to influenza A, H3, and 2. I know we're running out of time. I just want to mention that there are some other household characteristics that, again, are captured and we're using. We have a strong interest in understanding how these socioeconomic factors may drive or facilitate the occurrence of these infections, perhaps by providing the difficulty within the households to isolate effectively, to access preventative measures, etc. So for that, we're using the specific address of the individuals and connecting those with the neighborhood sociodemographic information using both of these indices, the area deprivation index and the social vulnerability index. I'm going to skip these because this is just a methodological approach that we are working in collaboration with some friends at the University of Georgia. These studies can be very fun, very interesting. They're very labor intensive. They require patience and a lot of good faith and great participation from individuals. So not everybody is willing to participate. Sometimes there's a challenge in trying to identify what is a true index case. And these studies usually start with individuals that require medical attention in outpatient clinics, and then everything else is done in the households. But you can imagine that if the infections are driven in some way by the severity of the disease, those index cases will tend to have more severe and maybe have a higher chance of transmitting to others. And again, tracing contacts from the community can be difficult, but it's necessary. A number of factors that need to be taken into account. This activity of the community can lead to addition to higher SARs. We know that there are other biological factors like the nature of the virus and the different variants that needs to be taken into account. Having samples from everyone is important. That can drive estimates of secondary infection risk. And the testing method and the frequency of testing is also important and needs to be taken into account. So I would just conclude saying that the households are interesting opportunities to study the transmission of viral infections among household members. And we can also use those studies to understand how the infections and how the disease occurs over time, how that evolves over time, and how the current and future vaccines may be working. And again, just I want to close just highlighting that there are a number of factors that usually play a role in these studies, and we need to take those into account. And I just want to finish acknowledging the participation of a number of individuals, especially the study participants and the scientific leads at CDC, FDA, our participating sites, and our team members at Vanderbilt. Thank you for your attention.
Thank you so much again for this terrific talk, Dr. Grijalva, and we're running short on time, so I think we just have time for one question. So sorry, maybe to the online audience, but if there's someone in person who has a quick question, we just have time for one.
What's the variation in the household crowding index that you see across the different sites? It seems like in other diseases we think about the number of people per bedroom, for example, as a considerable risk factor for transmission of respiratory disease. What kind of range do you see in your study?
So it varies by site. There are some sites that the usual household size is 2 individuals. In other sites, the usual household size is 5. And so we see quite a range. The minimum is 2. The maximum I think that we have at the moment is 12.
Okay, great. Thank you so much, everybody. On behalf of the Communicable Disease Dynamics, first, can we thank Carlos one more time? Everybody go look on the website to see the speakers that are coming every week. It's a great lineup. So thank you again. Thank you.